Hello everyone. Now today we will be continuing our nephrotic syndrome, and since we have discussed about the pathophysiology and clinical phases of nephrotic syndrome, then we discussed about the causes, in which we have divided into the rule of two, that is focal segmental glomerulosclerosis and minimal change disease. Minimal change disease was common in children, focal segmental glomerulosclerosis was common in African Americans and Hispanics. But the important thing, they both have the effacement of the podocyte in the electron microscope finding. So we can remember both of them. Then we can remember as amyloidosis and diabetic nephropathy, the systemic cause of nephrotic syndrome in one group. And the third group is membranous nephropathy. And we have talked about membranoproliferative glomerulonephritis and diffuse proliferative glomerulonephritis in the nephritic syndrome section. Since these two, in nephritic and nephrotic syndrome, the membranous term comes in membranous nephropathy and membranoproliferative glomerulonephritis. So we'll discuss this group over here, and then you will be a master of nephrotic syndrome. Okay, so continuing it, membranous nephropathy, the term membranous is indicating that there is something problem related to the glomerular membrane. Although we have talking that nephritic syndrome is the damage of your glomerular basement membrane, but when we are talking of nephrotic syndrome, we are already talking of podocyte layers, that there is a damage of podocyte layers. But in membranous nephropathy, the term membranous means indicating that there is a problem in membrane. And what is the membrane? That is glomerular basement membrane. Okay, and there is a nephropathy. So membranous glomerulonephritis. Actually, the term membrane comes where there is means membrane thickening. That is the important point you have to understand. Okay. So likewise, minimal change disease is common in children, focal segmental glomerulosclerosis is common in African American. Like that, membranous nephropathy is common in Caucasian adult. Why this ethnic group? Why this age group is important? Because in the case scenario, when there will be build up of a question, they will mention that a Caucasian adult or a African American or a children. Then it should be ringing in your mind that okay, now they are directing me towards the children means minimal change disease. If they are directing African Americans, then okay, they are directing you towards the focal segmental glomerulosclerosis, and diagnosis should come in your mind suddenly. Okay, then only you will be able to answer the second and third degree. Although you know that USMLE will not be directly asking you primary first order question. But if this thing doesn't ring in your mind, then you will not able to understand the second or third degree questions. So that is necessary. Okay, so we are talking about membranous nephropathy. Membranous nephropathy is the most commonly occurring Caucasian adult. Okay, and it can be idiopathic. You know that all the nephrotic syndrome can be idiopathic. That is maybe antibody to the phospholipase A2 receptor. But the important is always to remember the secondary cause. The secondary causes are due to the drugs like NSAID, penicillamine, and gold. Other infection like hepatitis B and hepatitis C, and syphilis infection, SLE or solid tumor. If you remember, this is very high yield actually. You have to remember this membranous nephropathy occurs due to the drug. Okay, due to infection like hepatitis B, hepatitis C, and syphilis, and SLE or solid tumor. Look, this is why important, because this hepatitis B and C infection was also seen secondary to the membranoproliferative glomerulonephritis. So this is responsible for your nephritic and nephrotic both syndrome. But if we are talking about only nephrotic syndrome, then what will be the cause? Maybe membranous nephropathy if the patient is coming with hepatitis B or C infection. Then your diagnosis may be membranous nephropathy or membranoproliferative glomerulonephritis, because both will cause the nephrotic syndrome. So you should have this in your mind. So secondary infection, very high yield hepatitis B, C, and syphilis infection. Okay, drug due to secondary to the drug, solid tumor, and SLE. If you remember, I have talked in the previous lectures about the SLE patient with nephrotic syndrome. Any SLE patient, if come with the will die, what will be the common cause? Renal failure. And if renal failure, then what will be why renal failure occurs in the SLE? The most common will be nephritic, not nephrotic, nephritic syndrome, and that is due to the diffuse proliferative glomerulonephritis. You are getting my point. Most common, this is very high. SLE, most common cause of death is renal failure, and the renal failure most commonly occur due to the nephritic syndrome. Okay, and that is due to the diffuse proliferative glomerulonephritis. If patient develop nephrotic syndrome, if we are talking, if Okay, if patient develop, which it is not common to develop nephrotic, it is common to develop nephritic. But if it is developed nephrotic syndrome, then it will be due to the membranous nephropathy. And since in SLE there is the development of nephrotic syndrome, in reality, in clinical scenario, there will be less case you will find, but in both you can find this. So you have to remember this. Okay. Now, solid tumor also in hepatitis B and C, it will look membranoproliferative also is secondary to hepatitis B and C. So you should be able to keep in your mind when they are talking about hepatitis B or C infection patient and developing this nephrotic syndrome, then it will be due to either of membranous nephropathy or membranoproliferative glomerulonephritis. That we need to have to check and balance. Okay, and then go further to find out the other finding to diagnose which is actually the infection. And I have kept here despite we have discussed previously, because this is necessary to differentiate as well. Okay. Then solid tumor. Can you tell me what is which was common in HIV patient? It was focal segmental glomerulosclerosis. So look, this infection are very necessary to understand and their association of the cause of nephrotic syndrome. Okay. Now coming to the light microscope findings, since there will be diffuse capillary and glomerular membrane thickening, I have talked about the membranous glomerular membrane thickening, immunofluorescence. This will be granular immunofluorescence due to immune complex deposition. What are the granular finding in case of the nephrotic syndrome? One is membranous nephropathy, another is membranoproliferative glomerulonephritis, another is diffuse proliferative glomerulonephritis. So two can be in both. The singly that will cause nephrotic syndrome is membranous nephropathy, where there will be granular immunofluorescence. And granular, you understand what means granular. It will not be a clear cut, it will be a granny appearance. This is granular. Okay. Now coming to the electron microscope. Electron microscope finding, we will find spike and dome appearance with subepithelial deposition. Means what? Means that there is the immune complex deposition. This immune complex deposition is under the subepithelium. You know that this is epithelial, this is GVM, and this is endothelium. Now we are talking about there is immune complex deposition, and immune complex deposition is where? On the subepithelial. This is epithelial and subepithelial. Since there is immune complex deposition, you know that there will be immunofluorescence will be granny. Since there is immune complex deposition, it will kick out this podocyte layer that attached to your glomerular membranes like this. Okay, with the tip. This is the glomerular based membrane. There is attached. Now it will kick off. Since it will be kicked off the podocyte, now what happened? This immune complex, this podocyte epithelial layer will be not satisfied, and it will try to cover the area where the immune complex has been deposition, and so it will form an extra layer and cover this immune complex. Okay, this is the extra layer form, and since there will be extra layer form, there will be appearance of this is the spike and this is the dome. This dome, spike. You are understanding this? This is the spike and this is the dome. This is spike and dome. So there will be a spike and dome appearance in your membranous nephropathy. Okay, subepithelial immune complex deposition. If you remember, in nephrotic syndrome there is only one condition, there will be subepithelial immune complex deposition, that is membranous nephropathy. If you talk about the previous one, there will be the post-streptococcus glomerulonephritis. In nephritic syndrome, that was subepithelial immune complex deposition. So don't get confused over here. We are talking about nephrotic syndrome only, and in nephrotic syndrome, the only place where it will be subepithelial immune complex deposition will be in membranous nephropathy, and other main electron microscopic finding will be spike and dome appearance, and that is very high yield, because this will be asked or this will be mentioned to make you diagnosis of membranous nephropathy. Also, there will be other association. They will give with the drug. They will give with HIV, hepatitis B, syphilis, or SLE, or solid tumor. There will be anything, but this should be present or asked. That is important. So it is very high yield. Spike and dome appearance in the with subepithelial deposited electron microscope finding. Are getting my point? Okay. Now let's move on. So this is the characteristics of your membranous nephropathy, that is responsible for nephrotic syndrome. Now membranoproliferative glomerulonephritis. We again know that we have already discussed this can be idiopathic, can be secondary to the hepatitis B and C infection. Okay, type 1, and there appears as a tram-track appearance on the HNE and pass stain. Immunofluorescence will be granular, same like here. there will be subendothelial immune complex deposits, and type 2 is intramembranous. So what we are talking about, the main differences from here is there will be intramembranous or subendothelial. These two we are talking about. Okay, if it is intramembranous, then they are talking about type 2. If it is about the subendothelial, then they are talking about type 1. So there are type 1 and type 2 in membranoproliferative glomerulonephritis. You have know about it. And okay, and now when you're talking about the tram track appearance, what happens? There will be the mesangial proliferation, cytoplasmic proliferation, and cut this immune complex and appear as the tram track. So there will be like this, two railway track appearance. Okay, and that indicates tram track appearance on the SNEM class. So membrane problem, proliferative, mesangial proliferate, and cut your immune complex deposition and glomerulonephritis. So name indicates a lot of things. Okay, and if you want to differentiate from membranous nephropathy by membranoproliferative glomerulonephritis, then immune complex deposition. Subepithelial is membranous nephropathy, intramembranous and subendothelial is membranoproliferative glomerulonephritis. And according to this, we can differentiate all the each causes of nephrotic syndrome and able to diagnose and manage the patient. After understanding this all series of lectures, if you go and give the Uworld and any question, I don't think that you will have a problem. You will be master in it. Thank you.